Thank you. The sun is shining in London, and we're delighted to welcome you to this webinar on our core research program. And this is our fourth webinar on our sort of overview series. And as I said a couple of seconds ago, very international audience we have from all around the world. And we've also got an international range of speakers. So we've got speakers from India, from Brazil. So what I'm going to do is hand you over to one of the co-chairs of the session, Professor Manu Mathur from the University of London, Queen Mary, and the Public Health Foundation for India. And he and his colleagues in India and Paulo in Brazil will be co-chairing this session. So over to you, Manu, and good luck with your webinar.
Many thanks, Professor Watt, and a warm welcome to everyone. Wherever you are, it's so nice to see so many people joining, many familiar faces, and joining from all over the world. As Professor Watt mentioned, this is the fourth webinar in the series of webinars which we are organizing under Project 4, which is a National Institute of Health and Care Research UK funded Global Health Group grant on oral health. We have previously talked about our work on oral health inequalities, on commercial determinants of health, and our overall plan for the project. And this is the fourth webinar where we will be speaking a lot about the importance of strengthening health systems in order to reduce oral health inequalities and extend the agenda which has been put forward under the Global Oral Health Action Plan 2030. In the next 45 to 50 minutes, what we are going to cover is the importance of researching on health systems to improve oral health. We will then have an example from a case study from Brazil from one of our very esteemed colleagues, Professor Paulo. We will then move on to discussing the features under the core program. What are the specific research activities we will be conducting under core program under the work package of health systems research, specifically speaking about one of the studies which we are doing. And then the stage will be open for questions and answers. Before I hand it over to the first presenter, it's a very interesting day for us because today, not only we are celebrating that the United Nations high-level political declaration on non-communicable diseases has got oral health featured in it very prominently, but in the same breath, there has been an objection which has been filed by United States of America saying that there was no consensus on the document which has been released. So interesting times in global health and in health systems research. So without taking any further of your time, I would like to introduce our first presenter. Well, he doesn't need any introduction. He's one of the most celebrated names in health systems research globally, Professor K. Srinath Reddy. Professor Srinath Reddy is the honorary distinguished professor at Public Health Foundation of India. He is the past president of Public Health Foundation of India and now the chancellor of the newly instituted Public Health University of Public Health Sciences in Hyderabad, India. He previously headed the Department of Cardiology at All India Institute of Medical Sciences and was the first Bernard Lown Professor of Cardiovascular Health at Harvard School of Public Health. He has got many accolades to his name. He has served on various committees and commissions all over the world, on various high-level government steering committees. And he is not only a teacher, but also an advocate and an activist who has advocated for reduction of non-communicable diseases and strengthening health systems. So he, unfortunately, because of his health, was not able to present in person today, but we have the recorded session from him. I would request my colleague Amit to please play the recorded session. Amit, can you please play it?
Greetings of the day. I'm speaking from New Delhi. I'm Srinath, the founder president of the Public Health Foundation of India, and recently designated the chancellor of the Public Health Sciences University, deemed to be university under the distinct category. I moved into public health because I believe public health has a very vital function in improving population health for everybody. Clinical medicine, whether practiced by a doctor, a dentist, or by anybody else who is a clinical care provider, is a very important function. Public health also advances that much further, because I believe that while clinical medicine delivers health in retail, public health delivers health in wholesale. We know also that medicine, dentistry have greatly advanced in terms of scientific research, which have elucidated the causes and the determinants of disease, and have also identified the pathways by which health can be advanced. We also have seen a huge host of technologies emerging which are revolutionizing clinical care. But if we are not able to deliver them to the intended beneficiaries in the numbers that need them, then we are failing to serve the social mission of science and technology. Science discovers, technology develops, public health delivers. And public health delivers through the health systems. So what we need to do is to create efficient, equitable, empathetic, and economically viable health systems that deliver a variety of preventive services along with health promotion, but also diagnostic services and effective clinical care whenever necessary, including palliation and rehabilitation. But in dentistry, which is absolutely critical across the entire life course, we have to focus a great deal, of course, on prevention and health promotion, but also on timely care. And that is what people who are actually dental health experts do. However, it cannot be restricted alone to a few people in the population, because the entire population does need good dental care at different points of their life course. In fact, there's nobody who does not require dental care from birth till the end of life. And we need to create competent, viable health systems for that. And research helps us to tell how those health systems should be configured and deliver in their functions. The purpose of research is to develop evidence-informed, context-relevant, resource-sensitive, equity-promoting, and culturally compatible recommendations for policy and practice. And these, therefore, need to be very closely aligned to policy under development and policy under implementation, so that the population benefits from all these recommendations. And in order to dovetail research into policy, we must recognize also that policy has several requirements. It needs scientific credibility. It needs financial feasibility. It requires operational steerability, and it requires political viability. Scientific credibility from basic epidemiological and clinical research. Financial feasibility from health economics research, which looks at both cost effectiveness as well as affordability. Then, in terms of operational steerability, we look at health systems research or implementation research. Then, in terms of political viability, whether the policymakers, the community, and other stakeholders are ready and receptive to receive our recommendations, we need social science research. So we require multidisciplinarity. But looking at the health systems research itself from the angle of implementation research, of whether what we are really developing in terms of our scientific recommendations are actually being delivered efficiently, we must consider the pathways. Otherwise, there'll be a secondary translational barrier, and many of the technologies will not reach the intended beneficiaries. So we need to focus on how health systems are configured, particularly in this era when the Sustainable Development Goals are focusing on delivering universal health coverage. That is target 3.8 of the SDGs. And there is a consensus all across the world, across countries, across agencies like the WHO and the World Bank, that there has to be a primary care-led universal health coverage. And if we are not able to get effective dental services from promotion to care into our primary care, we'll not really be able to protect the oral health of many people. I'm not only talking about dental health, but I'm also talking about overall ambit of oral health, including cancer prevention and cancer detection, and a variety of other oral health disorders. And now science has taught us how even the oral microbiome is linked to the gut microbiome, and they are influencing the neuroendocrine axis all over the body, from the neurological functions to the endocrine systems. So we recognize all these, and we recognize the relationship between chronic diseases and poor oral and dental health, particularly the poor gingival health. So given the fact that there are multiple conditions that are knit together and that oral health plays a great role in all of them, we cannot have a siloed approach to this in our health systems. And therefore, in primary care, promotion of oral health is absolutely important from a development point of view, and also to prevent a variety of other diseases which are linked to poor oral health. And this cannot happen unless we actually not only develop strong health systems and tell the policymakers as to how the health systems should be developed on the basis of our research, but also effectively monitor their implementation and see what kind of impact it is having. Because what we really want is knowledge to be translated into effective interventions which have impact with equity. And therefore, our health systems research becomes absolutely pivotal indeed. Even for policy, we have two streams of research. One is research for shaping policy, and second is research on how policy has been implemented with what effect. And there, health systems research becomes very, very important. And it is important, therefore vital for researchers in oral health to focus a lot on how their research can inform and influence health systems to become better delivery agents for a variety of health services related to oral health, and ensure that the benefits of science and technology are within the reach of everybody who requires them. And getting a very strong multidisciplinary approach is also very important, because when we talk about all of these elements like political viability or scientific credibility or whether financial feasibility or operational steerability, we do require multidisciplinarity in our research, and bringing in many elements is going to be important from the point of view of getting that cross-disciplinary mix. And health systems brings all of that together. And it's important for oral health professionals who are focusing on reducing the burden of oral diseases across the world, particularly in the low and middle-income countries where there's a lot of unrecognized and unattended burden, to make sure that their research is linked to credible health system interventions which will deliver with impact and equity. And therefore, I'm a strong votary for health systems research being coupled to every area of health research, and therefore oral health is also an important feature, because every single human being has to focus on oral health from birth to the end of life. And health systems, if they have to become sensitized and responsive to those health system needs of oral health, then researchers will have to shine the light on where the deficiencies are and where the solutions are. So I wish you all the best in your deliberations as you look at how oral health researchers can stream their brains into the area of health systems research. Thank you very much.
Thank you to Professor Reddy for this very inspirational oration. Thank you, Amit, for playing the video. So Professor Reddy gave us an overview of what is the importance of health systems research, and in a few minutes you will hear from us what we are doing under health systems research in Project Core. From a global perspective, now let's move to a country which has been an exemplar in health systems research for many decades now, Brazil. And we have our colleague, Professor Paulo from Brazil, who will be presenting the case study from Brazil. Just to introduce Professor Goes, he is an associate professor at Department of Clinical and Preventive Dentistry at Federal University of Pernambuco, Brazil. He has vast experience in the field of teaching, research, and management. He coordinates various teaching programs, various postgraduate programs in child and adolescent health. And he's also leading a research group on planning, management, evaluation of health services. He is also a very senior consultant with public bodies like Ministry of Health and local city councils. And he is leading our activities, Project Core activities in Brazil. So without any further ado, Professor Goes, if you can start your presentation.
Thank you, Manu. It's a pleasure for me. Can you hear me? It's okay. It's a pleasure to me to be here with you, especially our chair, Professor Amit Rajah, that it's a world reference and health research for all of us, and also my colleagues from the core program, Abhishek, Mehta, also Professor Richard Watt and Carol Herrera, who is the leaders of the core project. And my presentation today, I will just share under the core project what we are doing in what we did in Brazil, our last experience in terms of health research. Is it okay, the presentation? Could you tell me, Manu?
Yes, we can see it, Paulo.
Okay, great. Okay, I divide my presentation today. I am talking about how we connect with our last experience. Thanks for your kind words that we are a country that we are really look at evaluation of health service in the sense of improved quality. Today I will present for some of you the National Program for Improved Access and Quality of Dental Specialty Centers that we call here PMACCEL, and that is based on Donabedian theory of quality. And we present some results in the coverage of the first and the second cycle that was finished in 2018, and some results from the users and how these results could connect with the core objectives that I think that Abhishek will discuss later. Okay, as Brazil is a huge country, as all of you should know, to run a program like that, it's necessary that we establish partnerships in our national health, unified health system, what we call SUS, and we develop several partnerships with the most important universities in Brazil. The National Program for Improved Access and Quality of Dental Specialty Centers was created in the goal of monitoring and enhance the quality of services provided by the cells in Brazil, and was structured under the Donabedian theory of quality of health services. And we look at structure, process of work, include how services are delivered, and also the outcomes, how it affects on the population and clinical improvement, satisfactions, equity, etc. Well, the PMAX cell had with the objective to monitor in his quality and has two evaluation cycles, and the last one was finished in 1980, in 2018, sorry. And we incorporate to do this research different views, include the manager's views, the dental health professionals, the investigators per se, and also the users. Some of the main results of this project that we coordinate from the Federal University of Pernambuco was published at the volume 50 at the Community Dentistry or Epidemiology. All articles are open access. And just to share with you, uh, in the first cycle of the program, we evaluate 932 services, make an important step in institutionalizing a culture of evaluation. This cycle reveals significant structure and regional variability through user surveys and external assessment. The main dimensions analyzed include access and scheduling, reception, clinical care, environment and comfort, availability of supplies and equipment, and overall satisfactions of users. The findings show generally positive levels of user satisfaction, though they also highlight persistent challenges in access and the regional inequalities in services delivery. In the second cycle, we evaluated 1,097 cells. And I will just given a part because in Brazil, the dental health services in our national unified health system has approximately 2,000 teams of primary health care, and now we have approximately 1,200 dental specialty centers. In the second cycle of this program, we evaluated 1,097 services. And in this phase, we did a great emphasis in improvements related to the second cycle, like physical structure and accessibility, as well as a broader scope for external evaluation. Regional studies indicate that users reported a high levels of satisfaction. However, this cycle also revealed continued challenges, such as interruptions of care due to supply storages, also some cases of incomplete treatment, and the equity in the management of wait lists and users remain as a permanent challenge. When we compare the results of the both cycles, we find that several key dimensions can be aligned. User profile, access and scheduling, reception care, bonding, and accountability, such as prosthetics and availability of supplies, are overall in a good shape. However, however, the problem of equity in wait list management and how can we give access to the marginalized populations in areas with vulnerability remains a challenge. As we are a country with the big, huge regional differences in our dental services offers, And as we look at these results in terms of the theory that we apply to collect all the data, we can find that in relate to the first cycle, we have a kind of a huge heterogeneity among the cells and highly deficiency in accessibility and supplies. In the case of the process, we are always well evaluated, but we have a failure in planning, mailing, self-evaluation, and scheduling. And when we look at the users, we have a kind of a good satisfactions, but unequal access across different regions with the poor access in the poor regions. When we look to the second cycle of the PMAX cell, we see that the structures, we continue to have a progress in the infrastructures. It was good mainly for in terms of accessibility for those for people with deficiency. We did a lot of course and training for dental health professionals to assist those with some deficiencies. In the case of the process, we observed some punctual improvements in reception and also in bonding, but also the interruptions due to supply shortages. We ask us to look for training for the managers. In the users, we continue to observe high satisfactions about those who access the service but with persistent inequalities in wait times and list management. Also, with some empty areas of specialties to support the primary dental teams. And finally, just to I'm concerned about the time, we would say that the PMAX service trends evaluation and transparency in this kind of services in Brazil. We observed some structure improvements, especially those with deficiency, because it was a great investment. However, we have persistent challenges. The case of access, equity, and vulnerability focused planning is still a challenge. In this context, we have a great dialogue with the core program because the core program are asking us to reflect about how can we give a more accessible dental services, even though those who are in the primary care or those who are specialty care. But we are thinking about how we can manage and find a good way to achieve a better offer of these services. And now we are looking at and reflect as the Ministry of Health of Brazil asked us to start to think about the third cycle and revisit using some digital tools to continue this plan of health evaluation. We also include by the core reflections the use of mixed methods to clarify aspects related to absenteeism, planning difficulties, and access for marginalized population. This project was funded by the National Fund of Health of Ministry of Health in Brazil. The last cycle was in 2016. Thank you, obrigado. This is my email, and for those who would like to follow the team, Core of Brazil can access the ACT program Core Brazil. Thank you very much. I hope that I can contribute to the debate. Thank you, Manu.
Thank you. Thank you so much. Thank you so much, Paulo.
I think that I run on time.
Absolutely, Paulo. Always on time. Always on time.
Thank you.
Great to see Donabedian theory actually being implemented in practice. We have read a lot about the theory, but actually seeing it implemented to assess quality of care, it's fantastic. And I'm sure there are many learnings for us when we start our work packages and project goals. So moving from Brazil now to the nitty-gritties of what we will be doing under Project Core. And in order to introduce the work package on oral health systems research, we have Professor Abhishek Mehta with us. Professor Abhishek Mehta has more than about 70 years of experience in the field of dental public health, and he's currently heading the Department of Public Health Dentistry at Jamia Millia Islamia University in New Delhi in India. He is a reviewer and editorial board member of many prestigious journals globally, and is currently the associate editor of the Pierre Fauchard Academy journal. He has been an avid researcher and has served on many examiner panels in India and Nepal. And he is an excellent orator, lectured at various dental institutions, and is considered to be an expert faculty in systematic reviews. Professor Mehta will be leading the core program of research from India. So it's my great pleasure to welcome Professor Abhishek Mehta. So whenever you are ready.
Thank you, Manu. Thank you for such a big introduction. I don't think so I deserve that, but thank you so much. And I'd like to start with thanking the NIHR first for funding this, our core project, and Professor Richard Watt for including me in the team, all my uh, co-team, Carol, Paulo, everyone. Thank you very much. And it's really difficult to talk after Professor Reddy and Professor Paulo, but I'll try to do some justice to it. I'll just start my screen share. Just let me know if you can see my presentation.
We can see it, sir.
Can you see? Can you see?
Yes, yes,
Okay.
yes.
Okay. So, good evening, everyone, wherever you are there in the world. I am Abhishek, and I'll be talking about the work package 3, which is the health system reform of core project. Uh, this work package has to be implemented in all the 4 countries, but since I'm working in India, so I'll be talking a little bit about more about what we are doing in India. But let's start with why we need to have this work package. If we look at the WHO resolution and even global strategy on oral health and the action plan which has come, which has to be achieved by 2030, and the Bangkok Declaration, they are based upon certain 6 strategic objectives, which range from oral health governance, oral health promotion, health workforce, healthcare, information system, and of course, health research. So if all these package objectives we looked at, they're going to be successful only if we have is a robust health system in place. I'm saying the word health system because we wish to integrate our oral health into the overall health system, which is already in place. So that is the idea behind this work package. And when we say that, I'll just minimize myself. So when we say that why we want to have some research on oral health system in low and middle income country, like Professor Paulo also talked about from a middle income country perspective, that there are some success stories over there, but there are some lapses also, especially when we concerned about the marginalized population. So the marginalized population, if we see all over the world, which suffer from the less coverage are reside in the rural area and the urban slums, there is always will be a workforce shortage uh, because the people in this LMIC try to concentrate in the urban areas, and this leads to neglect of the rural area. So that there is a vast gap between a dentist population ratio between urban and the rural area. The third issue which we all come across is that there is a limited or no public or private dental insurance as such. That leads to a high out of pocket expenditure if somebody wants to go for a dental treatment because there is no public oral health infrastructure which is available to them. And oral health, as Professor Reddy told, that is still excluded from many national health priority, although we say that there is such a big burden of oral diseases, but it's not a national priority, especially in the low and middle income country. And yes, the oral health is often siloed, but I feel, that's my personal opinion, that we are also to be blamed for that. I can give you two critical example of that. If you look in my country also, most of the dental colleges are solo dental colleges. They are not colleges which are opened within a medical college. So obviously, if you're opening an independent dental college, you are going to be siloed. And the second example, which uh, is uh, is quite a success, but it is the opening of the tobacco cessation clinic in the dental colleges. Now, every dental college has a tobacco cessation clinic, which they are doing a great service by doing tobacco counseling for the dental patients. But again, it's not integrated with the overall health system or the medical college tobacco cessation clinic. So again, we are siloing ourselves away from the system. And lastly, the prevention is not prioritized. Even the intervention which are proven, like fluoride, have a very low uptake in low and middle income countries. So these six main issues are there, which hinders our uh, objective of achieving a universal health coverage, integrating with the overall health system, trying to reduce the burden of non-communicable disease, which of course the majority of burden is coming from oral diseases. And the third, which the Professor Paulo also talked and Professor Reddy also talked, the issue of health equity. So that health inequality is a big issue both in high income as well as low income countries, and of course to improve the quality of life. This is the master slide of our project. These are the work packages. So I'll be talking on the third work package, which is on the system reform. So system reforms, as Professor Reddy said, that we have to translate research into policy. And translate research is the main idea of doing research is to create an evidence. There has to be an evidence specific, context specific research which has to be done. So that evidence has to be built up, especially in the low and middle income countries like Colombia, Brazil, Kenya, and India. So to build up a system reform, we need to first determine the economic burden of oral disease. How much there is a burden of disease, how much the out-of-pocket expenditure or catastrophic expenditure is there from the oral disease if somebody wants to get the oral treatment. What are the possible barriers are there to access the dental services, even if they are available or they are available from at some distance, why people are not utilizing them, and based on that develop a certain integrated service model which for essential dental care, which will get ultimately integrated into the UHC. So the first work package is on the economic impact of the oral disease, and this across all the four countries, the study will be similar, and the objective will be mostly similar. The first objective could be to analyze the household spending from the existing national surveys or family health surveys which have been done in those countries. So it depends upon the countries and what type of data surveillance, oral data surveillance they are having. The second objective is to assess the extent of this catastrophic dental expenditure, uh, how much it's impacting their pocket, if they are able to afford it. And the third objective is if they are not able to afford it, are they avoiding dental care? They're suffering from the dental disease. That has to be known. And all this ultimately will go into to try to find out how much is the public coverage for oral health care in each country. So why we are talking about this is that even we think that dental disease is not something which is people will utilize it or people will spend their money. But if you look at from 27 European Union countries, where there is a strong oral health infrastructure, the oral disease treatment is the third most expensive treatment. after diabetes and cardiovascular disease treatment. So if oral health care has to be provided to each and every individual, it will cost a lot. So the mantra will be to have a prevention package or an essential oral health package in these countries, especially in the LMICs. If you look at India, sorry if I have the data of India only, it's not that it's very different from what we are seeing in the European countries. It could go a little down, but the treatment of oral disease is still in top 10. The cost of treatment is still in top 10 diseases. If whether we go for hospitalization or whether we go for non-hospitalization, or both in both the conditions, it's in top 10 most expensive treatment. And we always think that it's the dental treatment is inexpensive, and it's the cost of the transport, the lodging, and the food, or registration fee, which is taking major bulk of the expenditure which an individual or a family has to bear. But if we look at the research, almost 90% of the expenditure is coming from the medical or dental treatment per se. What the hospital is charging is almost 90%, whether you go for non-hospitalized cases or hospitalized cases. So this data breaks the myth that dental treatment is not costly for an individual. Coming on to what we have done, we try to find out the economic burden of oral disease in India, and we draw the data from 2 surveys which have a oral health component now. The first one is the longitudinal aging study of India, also called as LASI, and second one is the national sample survey office survey. This again, they both collect some data on oral health, or they have the questions on oral health. You can look at the sample size from both of them. If we see the NSSO, less than 1% are reporting oral condition, but the utilization, even those who are reporting the conditions, they have almost 85%. And LASI, which is for the older individual above 45 years of age, 47% are reporting oral condition, and utilization is decreasing actually. So as the people are aging, although their demand for oral care is increasing, they are not able to utilize for various reasons. Again, the inpatient care expenditure is more than outpatient care, and it's more in the urban than the rural area. If we divide this data based upon certain demographic factors like place of residence, we see that in both the surveys, the urban people are spending more on their dental health or on the dental treatment, and females are spending more on if we go for gender-wise comparison. But if the difference comes when we go for a socioeconomic status, where the lower class is spending more, if you look at the NSSO data, but if you look at the data which focus more on the aging part, the upper class is spending more in terms of US dollar for their dental treatment. So this is just a secondary analysis. Once we did the secondary analysis, the next step will be to try to find out the barriers which are there for the dental services. What are the different barriers to the access, and what is the preference for reforming these dental services? So this will be if you look at the major, this will be a cross-sectional community questionnaire survey, and we are trying to focus only on the disadvantaged and marginalized communities, and trying to find out their opinion or what they think of the major barriers are there when it comes to getting the dental treatment. So this will be a face-to-face interview using a structured questionnaire, and of course it will be translated into local language. So this still has to be done. So once these 2 studies are done, we will take the opinion of, as we are doing a bottom-up approach, once we got the opinion of the community, we did the secondary analysis of the data, we try to get the opinion of the stakeholders, the dental professional or the people who are involved in the oral health system. We try to find out what are the opportunity and barriers of reforming the oral health system in each country, and how a financial protection can be provided to each and every individual under universal health coverage for dental care. So this will be a qualitative survey. You will develop a semi-structured qualitative interview, and these are the stakeholders, which will include the primary healthcare professional, the head of various organization, association, community leader, the representative, health, the people who are involved in health insurance. They has to be known that why they are not covering dental treatment under their umbrella, why that is excluded. So this will be a consensus building exercise, and the stakeholder, we will follow a modified Delphi method where a questionnaire will be developed and it will be circulated to different stakeholders. They will be asked to uh, give their recommendation based upon the objective of the study, and of course there will be a scope for open-ended suggestions for if any additional strategies are there. Once that feedback is received, it will be summarized, and then the second round will involve to prioritize each and every theme which we have got. So there will be certain themes which we have got, and only on those themes we'll ask the stakeholder to prioritize what they think, the first one, the second one, and the third, fourth, and so on. So once that is done, the primary themes will be achieved. If there is agreement between more than 70% agreement is there for each theme, and a dissemination exercise will be conducted. So all these three studies will give us an idea what should be an essential oral healthcare package for a particular country, especially for the marginalized and vulnerable population. And then the study 3.4 will be the co-development and pilot testing of the reform delivery models of oral healthcare, targeting the disadvantaged individuals. So based upon that, a pilot study will be conducted to check the acceptability and feasibility of this newly developed dental care delivery model. So the main idea or main USP of this model is that it will be co-developed and pilot tested with the help of the community, the stakeholders, and of course the core project team in the field. It will be a mixed method pilot study where before and after design will be done, and there will be a continuous process evaluation between them. Pilot sites has already been selected for this study, and a community mapping exercise is already done just to know the demography, the type of health services which are there in that particular area, what are the people view and awareness towards oral health. So based upon whatever the community mapping exercise has been done, we will be doing the qualitative interview for around 600 to 800 adults per country, and a baseline and follow-up assessment will be done. Dissemination part for all the studies will be that all the results will be shared with the local stakeholders, the community groups, the international audience through presentation and publication. Maybe a nationwide symposium will be conducted to disseminate the study findings so that it reaches the policymaker. I'll stop over here, and thank you very much for your patient listening. I feel I have done some justice to this work package of the core project. Stop the screen share. I'm happy to take any question on this.
Thank you. Thank you so much, Professor Mehta. Thank you for explaining the different components under work package 3 of Project 4. With this, we complete our side of presentations, but this webinar would be incomplete if there are no question and answers, or if anybody wants to share their experience. So please feel free to unmute yourself and ask any questions. If you feel shy of asking questions, you can always type your question or comment, and we'll try to answer them as quickly as we can. It's a great privilege that we have got Professor Richard Watt with us. We have got Dr. Carol Ereno with us, and all our esteemed members from different countries who are part of Project Core with us. So please feel free to ask any of us any questions. Also, we will be putting in a link, an evaluation form. So bouquets, brickbats, good, bad, ugly, whatever you think of the webinar, we would be very happy if you can just fill out that evaluation form and help us improve. So over to you all now, and please feel free to ask any questions. Please unmute and ask.
Dr. Mathur, this is Dr. Pachava.
Hello, Dr. Pachava, great to hear from you.
Yeah, thank you so much. Thank you. Is there, I mean, in the coming days, can we hear about national oral health policy in India? Any idea you can share with us?
How should I answer this question? It will be out very soon. I think it is in the last stages of being released. So what I can say is that this year we'll hear the good news. Yes.
Okay, as you mentioned, the skill mix. So, is there any proposal from the? I'm not sure I mean, is there any proposal to improve auxiliaries, dental auxiliaries in public setup? Because the admission is also very low in India, I believe, dental auxiliaries, and we have only technicians or mechanics and hygienists and DORA, but there are very few takers, I think. So if, for example, what I have come across is in the field practice area, if a rural center is there with a dentist posted, they'll be deputed to some other centers in the remaining part of the week. So for 3 days in the main center and the 3 days in the other centers. So where there are no resources. So ultimately, the patient are referred to higher centers, and they are not referred to private institutions. So can that be like, in future, making them with private and public partnership? I think.
Any of the panelists would like to answer this? I mean, Professor Mehta, would you like to? I mean, I can have my.
Not aware of if it's a government policy for doing a public-private partnership through National Oral Health Program. But yeah, some dental colleges are doing it. I've heard about a college in Bhimavaram. They are doing some private-public partnership, and they have opened some, I think around 40, 50
not just colleges, because college is only just, for example, if we talk in Andhra Pradesh, we have 17 colleges, so they cannot work for 5 crore population of Andhra Pradesh. But maybe in private practitioners also can we inculcate them also in future. Can that be, because this is health systems, since it's been on health systems, can that be taken part?
There is a provision in the policy, Dr.
Okay.
Pachava. There is a provision in the policy, and what the policy talks about is in line with the National Universal Health Coverage Policy, which is PMJ Yojana.
Okay.
So the idea is that there will be a responsible and a controlled involvement of private sector. The modalities. So once the procedure is that policy is out, it will be converted into an implementation action plan, and through the newly created Jan Arogya Mandir and the revised, and the strengthened community health workforce, it will be diversified, and there will be some sort of task shifting which will be involved.
Okay. So one more last question. We often quote WHO recommendation of dentist population ratio of 1:7,500. Is it true? because I never found a primary resource for that. I always see somebody or other quoting it. So is it true that this is my last question? Because often our dissertations, theses, and publications are even, with this quote all the time.
I would keep my mouth shut. Anyone else would like to answer?
Well, let me come in. I think that's an outdated fallacy. So how can there possibly be a recommendation, a global recommendation on dentist to population ratio? It's an impossible notion. So I think you're absolutely right. The relevance of that is diminished. It's an old-fashioned relic, and I don't think we can think of one recommendation that would be applicable for all populations globally.
So what could be the ideal way of dentist ratio to population? Or is it target based, or is it population based, or is it need based?
I would say need based, but I can see Paulo's got his hands up.
Okay, thank you. Thank you very much for all analysts.
Just to contribute to the debate is that I think maybe it could be a dream what the WHO has made such a declaration. But I think that for the most low and middle income countries, this kind of organization has an enormous reputation, and it's very good because we need to have some directions. I mean, in Brazil, the funding of the National Unified Health System is co-funding between the federal level, the state level, and the municipality levels. For example, in the city that I live, that Recife, we are planning now, it was make a huge effort to cover 8% of the city with dental primary health care teams based on the recommendation that they need to put money to deliver the dental service for those who need more. I think that although it's a kind of, let's see, not compulsory, but I mean, I think that it's a great achievement to have a kind of recommendation mailing for those. I mean, we have different contexts and different countries, but Brazil and India are huge countries, and we are in the BRICS. We are looking alternatives for our economy, and that I think that something like in Portuguese, I would say that that's very good to have it, and worse not have this kind of recommendation. It's just a contribution.
Hello, Manu sir. Vishwa here.
Hi, Vishwa.
How are you, sir? Thank you so much. Wonderful insight from all of you. I have not a question, sir, actually an observation. In the public sector, I think rather than focusing exclusively on the skill mix, it is pertinent for us to also talk on skill upgradation to get thoroughly integrated into the broader primary healthcare delivery. Now, I actually recall a series of articles or publications by Dr. Glick, where the integration of dentists into the broader primary healthcare delivery is discussed at a clinical level. But if we can translate that into the public sector level, there is nothing like that. So I think that there has to be advocacy on that front as well.
Absolutely, you're bang on and right on the spot, Vishwa. If we can achieve that, and there are examples from all over the world where, and in fact this morning we have been speaking about skill upgradation. So your point is very valid and very well taken. We have Dr. Ramprasad's hand up. Dr. Ramprasad, if you want to unmute yourself.
Yeah, thank you so much, Dr. Manu. Good evening, everyone. Thank you so much for the interesting insights. I just had one question after hearing to all this. Are parallel courses in oral sciences being planned anywhere? Because it was discussed some time back, like BSc oral health and something like that. What about what is the trend in other countries? Is anything being planned? Any insights on that? Parallel courses to increase the manpower? Just your thoughts on that. Thank you so much. Thanks.
We have representation from Colombia, Brazil, United Kingdom. Anyone who wants to come in.
Just to augment the manpower, any parallel courses being planned to address the issues in rural areas and semi-urban areas, 3-year programs, 4-year programs, just to supplement what manpower is already existing in those areas? Just a question, just a thought. Thank you so much. Thanks.
If I might jump in, I just went to Chile a couple of weeks ago, and they have an interesting program. It's kind of a scholarship funded by the Ministry of Health for dentists to go to rural areas. They spend there either 1 year or 2 years, and when they return, the Ministry of Health funds their postgraduate education, MSc or clinical training. So it's an incentive is one of the strategies. I guess there are many, but for what I've heard from the colleagues there, is working, and many of them are, applying for this program, and they are practicing dentistry in the very remote areas, rural areas. Chile is like super long country. It goes to north from south, very different geographical areas. So it's quite catchy. And then the salaries also are higher, so to stimulate people to go there. So it's one example, it's one of the Ministry of Health initiatives, and it might work, maybe not exactly the same, but it could be something for us to think about. Thank you.
Yeah, thank you so much. Thanks.
If I may come, that it's there in India also, that especially the postgraduate have to serve some part of after they finish their post graduation. If especially from the government colleges, they have to serve in the rural area. They have a bond over there. In many states, it's there, and there is a
that's related to post graduation. What I was thinking was a parallel course. Now, parallel to the Bachelor of Dental Surgery program, we have BSc Oral Health program to address issues in rural areas. Something like it was being discussed some time back. So, any updates on that in relation to the Indian subcontinent, or in the new coming national oral health policy, or in other countries? That was the area of doubt. So that's thanks a lot.
Yeah, so this, although it's not a program as such, but the curriculum is going to be changed to a credit-based system now in future also. And even the University Grant Commission is saying that you have to have some online courses, but I feel it is mostly restricted to oral health education and not dental education per se, at least from Indian perspective. I can share an experience of Nepal also, that what Carol was saying, that if you work in an area which is slightly disadvantaged or far away from the capital city, they get a higher salary as compared to people who are working in Kathmandu. So that is also similar to Chile. We have a system. They have a system over there.
Right. Thank you, sir. Thank you so much. Thanks a lot. Thanks.
Any further question? I'm just worried about the time. But if we have got one or couple of more pressing questions, we can.
I think in our country, India, under the provision of this comprehensive primary health care, CPSC, we have established this Ayushman Arogya Mandir. Earlier, it was like health and wellness centers. So this mid-level healthcare providers have been deployed at that Ayushman Arogya Mandir, and they were BSc nursing along with the certificate course in community health. So in that certificate course in community health, the oral health care has been imparted. So we have trained those CHOs to take care of oral health at primary care level. I think there should be some evaluation from the team. So how it's going on, how it's working, and what's the economic means. I think I mean to say suggest that we can do economic evaluation of oral deployment of this CHOs at health and wellness centers. Thank you.
There is a very interesting question for all the panel members in the chat from Dr. Shaurya Tandon. He asks that if any of the panelists can share some experience from other countries on the integration of alternative medicine with oral health, as it is a huge science of healthcare, and what could be the way forward in the strategy for Project Core. So anyone in the panel would like to take this question? Anyone? Carol, Professor Watt. Well, Dr. Shaurya, I can start by just mentioning that China has a very strong system where they have included alternative systems of medicine, and in the World Health Organization's headquarters in Geneva, the alternative systems of medicine department contributes to non-communicable disease program, which includes oral health. So China is the classic example where this integration has happened. I'm not aware of any other program.
Manu, I can maybe just say that in one of our qualitative studies, when we've interviewed members of disadvantaged communities, one of the issues they raised was traditional medicine and their use of traditional medicine. And one of our MSc students here at UCL is going to be analyzing that data so that we try and understand a bit more about what communities experience in terms of traditional medicine linked to their oral health and what value they place on it. So it's an important area we need to understand more about, I think.
Thank you, Professor Watt. That's a very good insight, and we'll be looking forward to that publication. Dr. Ashwini, do you have a question?
Yeah, good evening, everyone. And they were wonderful deliberations. There was an interesting case study of Brazil, and it was really an eye-opener for even in the Indian scenario when it comes. I just had two questions related to that, actually. One is the utilization rate, because that was not in the slides. And I just was interested to know how the utilization rates were there after implementing this program. And second was the cultural barriers, if any were there, and how they were overcome and what challenges they faced and how they could overcome it. Thank you.
Thank you, Dr. Ashwin. Professor Paulo. Yeah.
I mean, I will try to explain because these specialty centers, they have a kind of grade, and also they have goals to achieve every month in different specialties. And the results show that as we examine all of them, it's not a sample of them, it's all of them, from the Amazon region to the extremely south of Brazil. Our investigators run a whole country. And approximately, I mean, it varies from specialty, I mean, to the endodontics to periodontics, from prosthetics, but I would say that in median, they achieve around 6 to 8.2% of the goals established by the Ministry of Health. One point that made us very curious is that around 25% of the users lost the appointment. And it's one of the papers that are published in the community in our epidemiology journal. But I would say that, I mean, in a median, they achieved 70 to 75.8% of their goals. Because we do not have a kind of utilization rate for these services, because we work through the service perspective, just those who arrive to them. We not look, I mean, a kind of a sample of people. We are work in the perspective of the service. I don't know if I was clear, but I tried to answer your question.
Thank you, Professor Paulo. I think in the interest of time, we should wrap up now. Thank you, everyone, for joining us, for taking out time.
Manu, anyway, I left my email in the presentation. I can put in the chat. If someone is interested in this particular results, we can send them. No problem.
Absolutely. And please do email Professor Paulo for any further question, Dr. Ashwini. Also, all the details are on our core project website. So if you want to contact any one of us who are involved in the project, please do visit our website. Please interact with us on social media. And, thank you, Paulo. Paulo has put it in the chat also now. And we'll be very happy to answer. Please participate in our capacity building activities. It happens, wherever you are, whichever activity is happening closer to you. Please do participate. This project needs your support, and I think we'll have some robust outcomes if you all support us. So thank you once again. Professor Watt, would you like to just conclude the webinar?
Yes, just to thank you and Abhishek and Paulo for your excellent presentations. Well done. And thank you everyone for attending and for good discussion. We had 126 people attending, the maximum number. So that's a world record for our core seminar so far. So well done. And our next webinar is on the 30th of October, and that one will be on community engagement and involvement, which is a very important and exciting part of our project. So if you're interested, do please join us on the 30th of October, and we'll send out more details soon. So thank you, Manu. Thank you, Abhishek. Thank you, Paulo. Great session and lovely to see everybody. And thank you very much, everyone, and goodbye.
Thank you.
Thank you, everyone.
Thank you,
Congrats, guys. Thank you. Take care.
Thank you. Obrigado.